Thank you very much, Tennille. It's for that kind introduction. It's a pleasure to be here. It's always a thrill to come to Australia, and it's not as cold as we were led to maybe expect. But it's a pleasure to be here. I want to thank the Leukemia Foundation, the organizers and sponsors, for inviting me to come and participate. And it's always a pleasure to come and talk with patients about MDS. It's what I do my research in, and the patients I take care of. Probably about 85% of the patients I take care of have MDS in one form or another. And so I'm very familiar with the disease and understand its implications for patients that have it. So I'm going to talk to you today about MDS, and these are my disclosures. We get research funding from a variety of sources in New York to help us run our trials and conduct our research. So I'm going to talk to you today about MDS, and so to just give you some background and some understanding about what MDS is, the bone marrow is one way to think about the blood production is the bone marrow is the factory that produces all the blood cells. And so blood has to be replenished continually. Blood cells last a few days to a few weeks to a few months, and a normal individual replaces 1% of all of their red blood cells every day, a normal individual. So if your bone marrow fails to produce blood cells, then the blood values are going to start to diminish, and you develop anemia or low white counts or low platelet counts, and as a consequence, the blood counts go lower. So when the bone marrow fails to keep up its production end, the blood counts go lower. So that is an impairment that occurs. And the Myelodysplastic Syndrome affects patients who are generally older. Middle 60s to middle 70s is the common age for individuals. The majority of patients develop bone marrow failure, and we worry about leukemia, but it occurs in about 35% of patients. So the majority of patients run into difficulty from anemia, from low white counts, and from low platelet counts rather than developing leukemia. And we have treatments that can delay or prevent that from happening as well. So we use a variety we look for causes for patients who have MDS. And in the majority of patients, we don't identify a specific cause. We know that patients who have had chemotherapy or radiation treatments for having had a prior cancer are at higher risk for developing MDS. There's a lot of data that has been developed over the years for patients who have heavy exposures to benzene as a chemical that can lead to the development of MDS. But the majority of patients do not have an identifiable cause for developing this disease. And most of my patients come in and always ask, why did I get this disease? And importantly, is this a hereditary disease? Can my other family members, my children, get this? There are some families that have MDS, but it's relatively rare. And so the main answer is that there is not a hereditary reason for the majority of MDS patients, and children of parents who have MDS don't get MDS as a consequence of their parents having it. There's been some data about the use of tobacco leading to the development of MDS. That is not an established fact. And again, there are some hereditary diseases that affect the blood that can lead or be associated with MDS. Those are relatively rare occurrences, and I'm not really going to cover that beyond what I'm talking about right now. With respect to age, this again just shows you that the majority of patients are in their 60s, 70s, and 80s, but there are people who have MDS as young as 5 or 6 years old, and I've taken care of patients well into their 90s who have MDS. So there's a very broad range category for people who have this disease. And again, the bone marrow is the seat or the factory that produces the red cells and the white cells and the platelets. And here you can see there's also a component of the immune cells that are important, that are produced by the bone marrow. And this leads to adult cells out in the circulation. And these are the cells that last from a few days to a few months in circulation and have to be continually replenished. And the red cells carry oxygen, the white cells fight infection, and the platelets help prevent bleeding. And in patients who develop myelodysplastic syndrome, we know that the environment in the bone marrow becomes abnormal, and this leads to incorrect or ineffective production of blood cells. And so the blood cells can't be formed naturally. They are produced in the bone marrow, but they often don't survive in the bone marrow to leave and go out and to form the adult cells into the peripheral blood. So the counts, as a consequence, the blood counts fall off. And there are a number of different factors that cause this to happen. We don't understand exactly what drives all of this abnormality. We're steadily doing research looking for this, and there are new mutations that have been described. But essentially what ends up happening is that you get low blood counts and you get appearance of immature blood cells in the bone marrow. These are called blast cells. They're early stem cells. And when they occur in increased numbers, in abnormally increased numbers in the blood, then this is one of the factors that physicians consider and take into account in making recommendations to patients about the necessity for treatments. So this just reflects poor maturation of the cells in the blood, and an increase in these cells is a factor that leads physicians to want to recommend treatment sooner for patients. There are many features of other diseases that overlap with MDS features. So physicians are careful about screening patients by doing bone marrow exams and other tests to distinguish patients who have MDS compared to patients who may have frank leukemia, myeloproliferative disorders, aplastic anemia, and paroxysmal nocturnal hemoglobinuria. So there are a variety of other diseases that physicians consider in the diagnosis of establishing a diagnosis for patients with a myelodysplastic syndrome. Again, MDS represents a very complex interaction in the bone marrow. The bone marrow produces the cells. Ultimately, the cells fail to mature and form adult cells that go into the blood. The cells often die off incorrectly or inappropriately in the bone marrow. And we've begun to identify a number of important gene mutations, genetic defects in the cells that are associated with the development of MDS in patients and that have important information that tells us about why patients get the disease and why patients are having certain types of behavior of their disease that are associated with some of these gene mutations. So once one establishes a diagnosis, one then tries to classify patients into groups so that we can then have some idea about how the disease is going to behave in an individual patient. So we use these classification schemas to try to group patients into categories to provide us with some hint about how some individual's disease is going to behave. MDS is a spectrum of diseases, from patients who have lower risk disease on the one hand and patients who have higher risk disease on the other. And a lot of patients fall in between in grayer areas with different expectations. how we interpret how a disease is going to behave in an individual patient helps us and guides us in terms of the types of treatment that we're going to recommend to an individual patient about the kind of therapy that's best for an individual with their disease. So classifications pertain to 100 patients, but remember that within the 100 patient category, there are patients who behave just like everybody else in that category, but there are patients on both extremes, some who have behavior that's different than the other patients in the middle of that grouping. And so classifications are important, but they're not an absolute guide for every individual patient. We've known for several years now that the onset of a regular transfusion requirement for an individual patient also carries prognostic information, meaning a disease in that individual is going to be a little bit more aggressive than a patient who does not have a red cell transfusion requirement. So we factor that in decision-making about treatment interventions. We also know that platelet counts are important. It helps, platelets are the cells that help prevent bleeding, and we know that patients with lower platelet counts have more active disease, and patients with lower platelet counts require treatments, interventions that patients with higher platelet counts may not require. So that's another factor that we consider. And classification systems change. So since 1997, we've had several iterations of classifications that have come and gone. And right now we have a new iteration that was developed about 3 years ago. And I can guarantee you that in the next 2 years, new information is coming out now that will change these classifications again. So the classification systems are only as good as the information that we have at that particular point in time. Yet they are a guide for helping us select and recommend treatments for patients. So right now we use the number of immature cells in the bone marrow, or the bone marrow blast, is one factor. The levels of red cells, platelets, and neutrophil count, and chromosomes. Chromosome information or cytogenetic information is another feature that we look at in patients. We get that information from the bone marrow, and that information is another guide as to what to expect about the behavior of an individual's disease. We classify patients based on parameters, and we break them into a variety of groups. And what we can tell from these groups is that there are patients who have the disease who are said to have very low-risk disease, whose disease may be stable for several years, not requiring treatment. And there are patients who have higher-risk disease who require treatment much sooner than patients with very low-risk disease. So we take that information about bone marrow blasts, blood counts, cytogenetics. We add in information developing about gene mutations, and we put these into formulas that allow us to classify individual patients and then use that to make recommendations for treatments. Some people may not need treatments, but just may be able to just be watched and observed because their disease does not require treatment as yet. Other people with higher risk disease may need interventions much sooner. And we're beginning to personalize therapy. So even though there's still a relatively small number of treatments that are available for specific patients with MDS, we're using new information that allows us to make more specific and better recommendations for individual patients. So there is new gene mutations data. This tells us that there are specific abnormalities of specific genes in the cells of patients with MDS. And what this information tells us is that these genes may be associated in patients who have more active disease, meaning that there may be reason to start treatment sooner rather than waiting. So maybe somebody with lower risk disease who has a gene mutation might warrant or merit an earlier start of treatment than somebody who doesn't have that specific mutation. So the details of which specific mutations are currently listed here are not as relevant in the sense that new information is coming out month by month about new mutations and new information. But the fact is that the information is becoming available, and we're beginning to use this now to help make treatment recommendations. And so this is just to show you that there are some specific mutations, such as the deletion 5q, which is associated with a specific ribosomal mutation in patients, that those patients that have this are very effectively treated with a drug called lenalidomide. This is an oral drug. Patients have a high likelihood of becoming transfusion independent, and I'll show you data about that, who take this drug. There are other chromosomal abnormalities such as monosomy 7 or trisomy 8 that respond effectively to a drug called azacitidine. And there are other mutations that are being identified that also may lend them to be more susceptible to treatments with a drug called azacitidine. And I'll show you some data about that. So the more information that develops, the better and more effective our choices are going to be for individual patients. So one of the key points, once established a diagnosis, and the diagnosis is based on blood examination, bone marrow examination, cytogenetics. We look to see what other diseases patients may have that may play a role in making decisions about types of therapy. And then patients should interact with their hematologists and have discussions about what treatments are best for them. And there are other resources available to patients. Treating institutions have resources, support groups such as the Leukemia Foundation on their website have information about drugs, about clinical trial availability that become very important resources for patients and their families. So once we establish a diagnosis and we've categorized the patient as to what the stage of their disease is, then we want to know which are the therapies that are available are most suited to individual patients. And so there are the drugs called hypomethylating agents. Azacitidine is the drug that's approved in Australia for this class of drug. So in the cells, there is an area in the DNA called the promoter region, which is an activator region in the DNA. And these lollipops represent a molecule near the promoter region. And this molecule is what we call normally hypomethylated, meaning there's not a methyl group. So this is biochemistry 101. So when there's no methyl groups, something called a transcription factor binds to this promoter region, and then the gene is active, and that's what we want, the appropriate genes to be active. These are like wiring in the walls of your homes. You flip on the light switch, and the electricity travels through the wires to the light, and the light goes on. However, if that light switch is broken, you may flip it on, but then the light doesn't go on because there's a defect in the light switch. Well, the cells are similar, and sometimes there are methyl groups that are added to these molecules, and what ends up happening is that these transcription factors now can't bind to the promoter region. So this is like the broken light switch in your wall, and as a consequence, the signal doesn't go from the light switch and the electricity to the light bulb, and the light bulb doesn't go on, and the gene isn't transcribed, and therefore the cell signal is erratic or broken. And so the cell doesn't get the right information about how to behave. And so one of the keys is that blood cells are not made properly. Azacitidine is a drug that can actually splice back together some of the bad wiring in the light switch, and as a consequence, the transcription factors now combine to the promoter region, and that gene can be restored to normal activity. Now, it may not be completely normal, so the light switch will go on, the light will go on. It may not illuminate completely as brightly as it did, but it goes on, and you get light. And so the signal is restored, and the cells can behave more normally. Blood counts can be better, and the bone marrow can function at a much better level. And this is one of the ways that azacitidine works. And why is this important? Because a long time ago, we tested out in patients with predominantly higher risk disease. We conducted what's called a randomized clinical trial, where patients were broken into two groups. Patients received azacitidine or supportive care. And what we found and demonstrated based on prior observations was that azacitidine had significant benefits for patients treated with MDS, treated with azacitidine. They had a much higher response rate, meaning their blood counts were much better. They lost the need for red cell transfusions. Their white counts were better. Their platelet counts were better. We prevented or delayed the onset of the disease turning into leukemia and the patients getting azacitidine. And we reduced the risk of the disease transforming into leukemia by 2.5-fold. So these were significant advances that hadn't been seen before in patients with MDS. And so this was an important observation. Another thing that we found was that it took a long time for the treatment to work. It takes several months. So it takes on the order of about 3 to 4 months, and patients can take up to 6 months to get a benefit from the treatment to show the clinical effects. So it's important for physicians and patients to understand that it can take several months before the treatment kicks in and works. And we also found that there was a reduction in the risk of leukemia. So the treatment can take several months, but there's almost an immediate effect of preventing the disease from moving to leukemia or getting worse. And so there was an 8-fold benefit for patients getting treatment initially compared to those patients who were just receiving transfusions and antibiotics. And we found that when we compared patients in the yellow curve versus the green curve, these are patients in the yellow who got immediate treatment versus patients where the treatment was delayed by the way we conducted the trial. We allowed patients who were getting worse to cross over and receive treatment, but these patients took more than 6 months before they started the treatment by the way the trial was designed. And what we found was that the patients who started treatment initially did much better than patients where there was a delay in the start of treatment. So this taught us that starting treatment in the patients that we treated in this trial was much better for patients than waiting and watching if they had higher risk disease. So this was an important observation. And Erin, I think, is going to talk to you about quality of life, which is another important aspect of what we measure. If we give treatments and we make the blood counts better, but patients don't feel better, they don't function at a better level, they can't do more, then we wouldn't necessarily consider that a successful outcome for patients. We want patients to be able to function at higher levels and really participate in their normal lifestyles. And what we saw was that transfusions lost their effect with respect to fatigue, shortness of breath, and overall physical functioning. But when we started the treatment with the azacitidine, patients' physical functioning got a lot better and their symptoms diminished and they felt better. And they were able to function at a higher level. So the treatment helped restore their functionality better than red cell transfusions was able to. And then we went on to conduct a second trial, which confirmed all of our prior observations. And in addition, we found that the outcome for patients was much better receiving the azacitidine compared to patients who were receiving other types of treatment. So what we really helped do with this trial and the trial before it was establish azacitidine as the standard of care for patients with higher risk MDS. And this has really now established this drug as the first-line therapy for higher risk patients globally. In every country where azacitidine is approved, it is accepted as the standard of care for patients with higher risk disease. Now, there are patients, as I mentioned, the classifications change all the time. So in the classifications we used originally, some of the patients now would be considered to have acute leukemia, but in certain classifications, we still call these patients MDS, not leukemia. So higher blast counts in some categories are called leukemia, some are still called MDS. This slide just says that patients who have higher blast percentages, and even though some categories would call them leukemia, they can still benefit from azacitidine in a significant and beneficial way. And we also show that azacitidine was effective in reducing the need for red cell transfusions and platelet transfusions, reduced the need for hospitalizations in patients, and reduced the risk of developing infection. So azacitidine was effective in a number of varieties for individual patients. And I started out by saying that this is a disease of older individuals in their mid-60s and mid-70s. And in the United States, we see it's what I'll call ageism. There's a trend to say that older individuals should be treated differently because of age. And as I mentioned, I have patients in my practice in their 90s, so we don't consider age an important factor. As a matter of fact, age has never been a factor with azacitidine treatment. Older individuals respond just as well as younger individuals. And a friend of mine treated a patient who was 102 years old with azacitidine. So there really is no age limitation. Comorbidities, other diseases, are important. So if somebody has bad heart disease or bad lung disease and they're 60 years old, they may not be as good a candidate for treatment as a 85-year-old who has just MDS but has otherwise good health. So that's a factor that's important. And this just shows that individuals who are over the age of 75 did much better than patients receiving other types of treatment. So older individuals tolerate treatments very well with who have MDS, as long as there are other systems, heart disease, lung disease, and other kidney disease and things like that are not a significant challenge or problem for an individual patient. Now, we also talk about response, and response is important. So overall, about 50% of the patients respond to azacitidine, but only about 17% of patients get a full normalization of their blood counts. And what we showed in our trials was that actually patients who just had an improvement of either their red cells, their white cells, or their platelets had a significant benefit in responding and their outcome. So you don't have to have a complete remission with azacitidine to get the benefit. Just an improvement in one blood line is good enough to convey the benefit for patients. And partly this is probably because we continue treatment for patients for prolonged periods of time. One of the other things that we found was that if you stop treatment after patients get to an initial response, which is something we used to do in cancer types of treatments, we found that the disease, the MDS, tends to come back. So right now, and for a long time, we've encouraged patients and we want to treat patients for as long as they're benefiting, we continue treatment. And I have patients in my practice who have been on treatment with azacitidine for 3, 4, 5 years and more, receiving their monthly treatments. And so we continue treatment. And what we found was that patients who initially start out with and get a degree of response, by continuing treatment can have a much greater degree of response, but it may take 6 months to a year before they finally get to that level of maximal response. So if we stop short of that, we'll find that the patients may not get to that level and that their disease comes back. So our strategy is to continue treatment on an open-ended basis because we find that patients do better and they stay in their response states for much longer periods of time by continuing treatment. And this just shows that the two randomized phase 3 trials, these are where we compared one drug to a standard. In the case of azacitidine, these are the two trials, were significantly better than the comparators that we tested against, whereas the other drug, the other hypomethylating agent, which is called decitabine, this is a drug that you may read about online because it's available in a lot of sites around the world. It's not available in Australia at this time, but decitabine was tested in a similar vein and was not found to be better than the drugs against which it was compared. So azacitidine as a standard of care for patients with higher risk disease, and these are the two trials that helped establish that. So I started off by talking about higher risk disease. Now let's just change gears and go to lower risk disease for a couple of minutes. And so for patients who have lower risk disease, don't have high blast counts, don't have very bad chromosome abnormalities, but may just be anemic, patients can often be treated with a drug called erythropoietin, and another drug called filgrastim or Neupogen may be added to that. And there are algorithms, there are ways that we can assess what the likelihood of a patient responding may be. So we look at the serum red cell hormone level, erythropoietin, in patients, and we look to see how many transfusions they're receiving. Essentially, if you have a relatively lower burden of red cell transfusion requirement, erythropoietin may be effective in reversing the need for red cell transfusions. Azacitidine has also been tested in lower risk patients. It's not routinely used in Australia for lower risk patients. Nevertheless, it has a response rate of about 50% in lower risk disease patients. And this just shows, again, data from a trial comparing different doses and schedules of azacitidine, and here we found, again, about 50% of the patients with lower risk disease can respond. Now, I mentioned before about lenalidomide in patients with what's called a deletion 5q. This is a very specific chromosomal abnormality in patients. And this just summarizes a number of different trials. And what it shows is that patients who have the deletion 5q have a response rate of about 67%, meaning about 2/3 of the patients have an elimination of the need for red cell transfusions. If you have lower risk disease and you do not have the deletion 5q, then the response rate is about 25% for patients who receive lenalidomide. And this is a trial that was conducted predominantly in Europe, presented at the international meetings a few years ago, looking at two different dose levels. And again, the take-home message here is that patients who have deletion 5q can respond, and that the 10 milligram dosing was deemed to be the standard dosing in this grouping, and there were no long-term negative effects from the administration of lenalidomide to patients. So there's been literature about the risk of developing leukemia in patients with MDS treated with lenalidomide. None of the studies have borne this out, so that is not a concern for patients. And this was a trial that was just reported on a few months ago. This is in patients with non-deletion 5q. And here patients were randomized to receive either lenalidomide or a placebo, a pill that did not contain the active drug. And here the response rate was, again, about 27% transfusion independence for patients receiving lenalidomide compared to only 2% or 2.5% for patients who received the placebo. So this bears out that patients with lower risk disease who don't have deletion 5q can respond to lenalidomide. Now, for patients who have lower risk disease, who receive a lot of red cell transfusions. There can be a buildup of iron in the system. And we know that when this happens, this can damage the heart, the pancreas, and the liver. And that can lead to heart failure, to liver failure, and to diabetes. And so we suggest to patients that where there is a continuing need for red cell transfusions, that we begin medication that can help pull some of the iron out of the system. It's called chelation treatment, and there are a variety of recommendations that are made. It's predominantly recommended for patients with lower risk disease who have over about 20 to 30 units of red cells over their lifetime, and that we do chelation. And chelation can be effective in pulling out the red cell, the excess iron from the system, and can delay or prevent the damage that can occur to the heart, the liver, and to the pancreas and to other endocrine organs. So this can be an effective administration. It can be administered intravenously as an infusion into the skin, and there are chelation formulations in pill form as well. So that covers the two main drugs, and these are the two drugs that are available in Australia, azacitidine and lenalidomide, along with erythropoietin. Just so you know, there are a number of other drugs that are currently in clinical trials, and the drugs that are available in clinical trials can be obtained, that information can be obtained either from the Leukemia Foundation website or from the Australian government website, and there'll be some more information I'll give you at the end for those two web addresses. So the field is moving more now in the direction of looking at a variety of combinations of studies. So I've said before that the response rate to azacitidine is about 50%, which means that half of the patients don't respond. So we need to make responses better for all of the patients. And so we're trying to do this by combining drugs. So this is a combination of the two drugs that are approved here, azacitidine and lenalidomide. This produced a 67% response rate in trials in predominantly the US. In New York, we've been interested in a combination of azacitidine and another class of drug called vorinostat, which is a histone deacetylase inhibitor. This produced a response rate of about 75% for the combination. And in studies that we conducted, we saw that the patients who had the standard dose of azacitidine with one of the groupings of one of the doses of vorinostat did much better overall, and did better than what we thought they would do with azacitidine alone. And what needs to be done is more testing for these types of combinations so that we can see whether they are going to be better than the single agent of azacitidine. So these are still considered investigational approaches and not standardized approaches yet, and more work needs to be done to determine whether they're going to be better than the single agent. One has to weigh both the benefit and the side effects. And side effects can be substantial in patients and may lead to individuals not wanting to take the combinations of drugs or may not being able to tolerate the combinations of drugs, which is why we do these in trial formats so that we can test and ascertain whether the combinations are better than single agents. So even my 85 and 90-year-old patients come and ask me about bone marrow transplant. And I have to tell them that there is an age limitation. So there's no age limitation to receiving azacitidine or lenalidomide, but there is an age limitation to receiving a bone marrow transplant or a stem cell transplant. It used to be 60 years old was the cutoff, then it was 65. In my institution, we still do stem cell transplants for patients as old as 75. It's not benign treatment. There's a lot of risk. There's a lot of side effect. Patients are in the hospital. There is lots of concerns, so we're very selective in the 75-year-olds that we would consider for stem cell transplant. This is an option mostly for younger individuals. It pertains only probably to about 15% of the MDS population. But still in all, it is a potentially curative strategy for the select patients in whom we make the recommendation. And certainly for younger patients, it is an important consideration because it can cure younger patients, but patients with higher risk disease have high rates of relapse, and so we have to lower the risk of the higher risk patients into lower risk categories to make stem cells a better option for them. I'm going to skip this slide, and then I'm going to tell you that when patients fail a hypomethylating agent, when azacitidine stops working, then we have limited options for individual patients. And both in the US, globally, in Australia, and many other sites in between, there are not very good options for individuals. There are options, but they're not very good. So we're continually looking for new drugs that can be better for patients who fail treatments with azacitidine. And this is just a partial list of the types of treatments that are being looked at. There's a drug called rigosertib that's going to start clinical trials here in Australia, specifically for patients who no longer respond to azacitidine. And there are other drugs that are in combinations with azacitidine being looked at in patients who fail azacitidine as a primary treatment. And rigosertib is a drug that we're now combining with azacitidine in the US. So this is the results of a trial of rigosertib that was just presented at the hematology meetings in December. And essentially this was for patients who have failed azacitidine. Patients were treated. Patients could respond to the rigosertib, and there were some subgroups of patients that fared very well who received treatment with rigosertib. So these were patients under the age of 75, patients with higher risk disease, and patients who had not received azacitidine for a very long period of time. So patients who had received azacitidine for 9 months or less did better. And this drug is now going to be tested in a phase 3 study again. And patients who meet these parameters will be eligible for this type of study to see if it will help them after having failed azacitidine. Now, we've been combining azacitidine with this drug rigosertib, and what we've seen is that about 60 to 70% of the patients that we treat with the combination respond. And we've seen that some patients who fail to respond to azacitidine or stop responding could respond again once we added the rigosertib to the combination. So this is still an ongoing trial, and we'll need more information over time. Now, azacitidine is given as injections under the skin, and I think intravenously. Here in Australia, but there are trials ongoing with an oral formulation. So we've reasoned that if it works under the skin as injections or intravenously, and it was shown years ago that it could work given as an oral drug. It's now being tested as an oral drug to see if it will help patients with MDS who have lower risk or higher risk disease. And this is just data from a trial that was reported at ASH, the hematology meetings a few years ago, that shows that azacitidine given orally can produce responses in patients with disease, with MDS. Now we're testing it in a trial that will begin at several sites globally and is yet to be determined whether it will open here in Australia, where in patients that fail azacitidine given intravenously or under the skin. They will be given azacitidine as a pill, and we'll see whether this will help patients who are not responding to the drug given as an injection. So I've tried to cover a lot of the standard of care of MDS. And so for lower risk disease, there are a variety of options that range from just watchful waiting until patients need transfusions, and then erythropoietin may be an option. Lenalidomide or hypomethylating agents, azacitidine, can be an option. And this can include investigational approaches and including stem cells. For patients with higher risk disease, azacitidine is the standard of care for frontline initial therapy for patients. And if that does not work, or if it stops working, then we can look at a variety of investigational approaches, including stem cells for individuals. And I just want to leave you with a few key points about treatment with the 2 drugs that are approved, azacitidine. Responses occur in about 50% of patients. It improves the quality of life and can render patients transfusion independent for red cells. It reduces the risk of the disease getting worse and moving to leukemia. It's associated with a significant benefit for patients, and we recommend continued treatment with maintenance azacitidine monthly treatments because it results in better outcomes for patients. We use a standard dosing, 1 week of treatment out of every 4. We don't lower the dose initially, even for patients who have low blood counts. It may take up to 6 months for the treatment to demonstrate its clinical effect. And patients should receive at least 4 to 6 months of treatment as long as the disease is not getting worse. Now, in 50% of the patients who start treatment, the blood counts may get worse before they get better. We know that. We expect that. And patients tolerate that. The greatest risk for patients is from their disease and not from the treatment. And the treatment effects, lowering the blood counts, can be managed effectively in patients. Now, with respect to lenalidomide, about 2/3 of the patients have an elimination of the need for red cell transfusions. The duration of response is more than 4 years for patients who have the deletion 5q. If patients don't have deletion 5q but have lower risk disease, about 25% of the patients will have a response. The median duration of response is shorter for non-deletion 5q patients, about 8 months. And the side effect profile of lenalidomide is that of a well-tolerated drug. There are clinical trials that are available, and that there is a Victorian clinical trials app that patients can download, and the Australian government clinical trials website is nationwide. And I will stop here. Thank you for your attention. Be happy to answer any of your questions. And thank you, and as they say here, good day.